So what we're going to concentrate today on are the visits that are being provided by you, the nurse practitioners, in the home setting, in assisted living, the various locations in which you provide services. And one really nice thing to what we're doing right now is, as I'm sure you're all very well aware at this point, we are asking the practitioners to start to assign the E&M code, which is the Evaluation and Management Code, and that's the visit code. All the visit codes are called Evaluation and Management. The Evaluation and Management codes for the services that you're providing in that home or assisted living location. So they're your evaluation and management. They're all, we call them also the 99 codes. And I know that you all recognize them also as level 1, 2, 3, 4 codes that are there. So they're all the evaluation and management services. And that's really what we're going to concentrate on today, is what has to be in the documentation when we assign those codes. Another really great thing for MDTU, Almost Family, and the LHC group is, as we've been working with your EMR, and you've got Sandy and Amanda, you've got lots of people working on your behalf on the EMR. And just a reminder, if you dialed in, if you could mute your phones, that would be great, because then we won't have the background noise for anybody who dialed in. And if you want to ask a question when you're doing it, just unmute your phone at any point and ask a question. Since we're recording the session, that way we'll have it. But if your phones aren't muted, I can hear all the background noise on your phones. Thank you. So if you have questions, like I said, please stop us and ask, because we want this to be an educational session. And again, I know most of you have started doing it. And we're going through, just so that you understand the process we're going through right now, we still have 100% of your services, 100% of them are being coded by your auditing and coding team. So that is not stopped. Jen and her group are still looking at every single solitary service. And what we're doing to help with the education process is, when the coder is coding your service that you send in, and we look at what you assigned on that service for your E&M service, we're identifying where the coder and you, the provider, might not agree on what the level of service is. We're having a second look at every one of those where there's where the two codes don't match, so that we can identify opportunities for education for either on the coders, on the practitioner side, so we can get feedback to you if you're assigning a level of service and the documentation is supporting something different. So it's a really great process, and again, 100%, even though you're working through a Premier, you're working through the system, and you're identifying those codes that are in there, 100% of them are being coded out by your coding team, by Jen and her coding team, the coders and auditors. So unless I have questions related to that, I'm going to get started with the rest of the presentation. At least I think I am. There we go. So I just wanted to give you and I know most of you know all this stuff, but just general principles of documentation. We're going to refer to CMS, which is the Centers for Medicare and Medicaid. That's our primary payers for most of the services that we provide. Medicare and Medicaid provide most of the, we do have Blue Cross and Blue Shield, United, some others, but we always follow also CMS rules. Unless we have a specific indication from another provider, payer to do something different. But CMS, we generally consider what we follow across the board, so you don't have to worry about who a payer is. We follow the same guidelines across the board for all payers, and we follow CMS. One of the things they look at is CMS does say that practitioners are expected to complete the documentation for services during or as soon as practical after it is provided in order to maintain an accurate medical record. CMS, again, Centers for Medicare and Medicaid, don't give you a specific period of time in which that has to be done, but it is reasonable to expect that it would take no more than a couple of days. But ideally, most organizations require that documentation is done the day in which it was provided or within a day after. And I know we have a little bit of leeway on the services we're providing for the documentation, but I will tell you that when we go through our audits and reviews, services that are documented several days later, when we go back, the question that comes into play always is, how can you remember days later what was done for a particular patient on a particular day of service? So that's why we ask you, even when you're having trouble with your connection or getting into the system, if you're taking notes in order to put the documentation in at a later time, I will tell you to do it as soon as you can do it afterwards, because services that are documented days later, again, do become problematic. The other thing I just wanted to point out is, if you're going to addend a note, sometimes we might be waiting for a lab result to come in, or you might be waiting for something to come back. If you're going to addend a note, make sure, and in the electronic system it's much easier, but the date that a note is addended, that we put the addendum in there, is the date that goes on that note. So if you're going to addend a note, do an addendum on a note today for a service that you provided a week ago, we generally, it'll come up with today's, you want it to have today's date and say you're addending the note for what the date is. And we also are addending notes because we may find out again when you went into the electronic system, a section of the note didn't come in, and perhaps it might have been connectivity or something like that. But again, if you go back and addend a note, we addended the date in which it's addended. We put the addendum on as a date that goes in there. Other medical record documentation principles include that it's legible and complete. Again, in the electronic system, that's generally not an issue that we have in other, when we're handwriting our notes. If you do write a handwritten note because there's some problem with the system, again, make sure it's legible and complete. And that encounter includes the reason for the service, our chief complaint, histories, exams, the medical necessity, decision-making that goes into there, any pertinent labs or anything that you reviewed, clinical impressions, your plan, your date, and your legible identity of your provider. Then from that note, that documentation, that's where we derive out the CPT code, which is that E&M visit code, and the diagnosis codes to support that documentation. So that's what we do the billing from. We do the billing just like you will when you assign what the CPT code is, and the diagnosis code, it comes directly from that note for that day. E&M services that are important, it represents all the cognitive work that you've performed. And I think that's sometimes what we miss out in some of these electronic notes, and I know that that's what your organization has been working so diligently for, to help the providers in that documentation, that we're documenting the information that represents the work that you did for that service and what needed to be done. And they're working really hard to eliminate unnecessary documentation just for the purpose of documenting something. We want that note really to stand there, to stand alone each time, to show what it was you did that day and the cognitive work that you went in to make your decisions at the end of the day, at the end of that visit. So that really is an important piece, and we're trying, again, they're trying to eliminate unnecessary documentation in the notes so it actually represents what was done that day and your work that was performed. These E&M services are the significant portion of your services. Almost all of the CPT codes that we bill are E&M services. We bill some annual wellness. We might bill some other services that are going on, but for the most part, this represents probably 95% of the services that you're doing are those E&M services. We tell you that also, unless the services is coded and documented to the appropriate level and meets the medical necessity, then noncompliance can result, meaning that we don't want you to underbill and we don't want you to overbill. If you provided a service at a high level, we want you to make sure that that's documented, and we want you to bill at that level of service. If you provided a service that was lower level and it was fairly straightforward, then we want you to code it at that level also, because each one also looks at medical necessity, that the level was appropriate for what the chief complaint, the reason you saw the patient for. The primary rule always has been, if it's not documented, it's not done. That was really our old rule in the old days when we used to handwrite our notes. The secondary rule now, if it's done and documented, was it medically necessary to do? So that gets back to making sure that what we document in the note was medically necessary to do that day, and we weren't doing it for the purposes of coding a service. And again, I really applaud your leadership, because they've really worked to make sure that what goes into that note is what you needed to provide that day, and to eliminate unnecessary documentation for you. So there's two types of visits that we have. We have your new visits and your established patient visits, and that's for our outpatient services. That would also be for any offices or our preventive services that we're providing. And just, the definition of a new patient for billing E&M services is a new patient is a patient who has not received any professional services, a visit note, an E&M, or other face-to-face by anyone within your same group in the last 3 years. So when I was there, I did have the opportunity to be able to visit your location, and I was able to watch the intake process and the scheduling process for all of you. It's such a highly integrated system. It's amazing what a great job your group does to put together your schedules, etc. One of the calls that I did have the opportunity to listen on was a new patient that was calling in, and it was interesting because the patient was actually a patient for MDTU about 2.5 years ago, and we were scheduling a first visit for them. They were scheduling a new first visit for them. They had not been a patient for about 2.5 years. And when that first visit goes for the purposes of billing, that's an established patient for billing. So one interesting thing for our providers is they don't always know that. You might know because the patient said, oh, I used to be with you 2 years ago, or you might be able to see it somewhere in the system, but we don't always know that. But I will say that for billing purposes, if you build a service as a new patient visit and they were seen, it would come back and it would generally hit an edit to let us know that that's an established patient visit for billing. The other interesting thing is on those new patient visits that are actually for billing established patients, you're probably going to do all the documentation and all the services you would do for a new patient. You're going to regather all the information as if it's a new patient, but it's for the coding, the selection of the code that goes out as established if you know that they've been seen in the last 3 years by any of the other providers in your group. So I think that's an important concept. It is one of the areas that sometimes we get miscoding for because the provider that was providing may not have realized it. I know we're trying to identify, I don't know if Sandra, the group, so I know we're trying to identify a way to be able to indicate that for you, but just so when you're selecting the code, even though you're putting it in, you think it's a new patient, if you know they've been seen, it would be established for billing. So all those E&M services, those E&M services have what we call the 3 key components, and that really is the crux of the documentation you're doing. And as you've been in the EMR, you are certainly aware of these different areas that are in there. The 3 key components we consider are the history, exam, and the medical decision making. We also have what we call the contributing or assisting components, which are counseling and coordinating care, which I'll talk just briefly about. We're going to expand the education on that, I think, in the near future, and the nature of the presenting problem and that time element, which generally goes into counseling coordinating care. So I put in here that although many providers equate a level of service to the component, to the amount of time spent, it really is the 3 key components that determine the level of services for most of them that we're providing at MDTU through Almost Family and LHC. It really is those 3 key components, the history, the exam, and the medical decision making that determine those. So what I'm going to spend the time today, really this next portion doing, is putting that piece of the puzzle together, what the history exam and medical decision-making do to come together to end up having you select that E&M level of service, new or established patient. So the history, which we really focused on the history of the present illness or the chief complaint, the reason we're seeing the patient, then that physical exam and the medical decision-making. So when we determine the level of service for the history, there's actually 4 levels of a history. And I know that going through the process, you won't be having an audit sheet there checking all these boxes. Although your EMR does a nice job helping in some of these areas for you to understand how many different components of each of these key components you did document on. But there's 3 levels of a history. There's a problem-focused, an expanded problem focus, a detailed, and a comprehensive. So when we look to select the history in the end that's going to go in as a key component, the highest level services, your level 5 services, will require comprehensive histories. Your established patient, next levels down will require detailed, and so on. So obviously the lower level services require lower level history, and the higher level services would require a higher level of documented and medically necessary history. So the history, first piece is the chief complaint and the history of present illness. And it's interesting because the chief complaint and history of present illness go into that first portion of the history, and they're required for every single E&M service. We have to have a chief complaint or history of present illness for every single service. The chief complaint is required. And we do say that your chief complaint can be included in your history of present illness. So the reason for your visit may be part of your HPI components. So even though we might have a chief complaint area up there, the elements of that chief complaint can be part of your history of present illness. So the real focus for that present illness or the reason for the encounter is what generally generates the level of service that's going to be billed in the end. Like, why did we see the patient today? Are we seeing them because you got called because the daughter said that she's been having a cough for the last week and a fever? Is that the reason? Or are we seeing that patient because we're scheduling them to see them because they have chronic conditions and we're following them up on the chronic conditions? So that's really what we're going to look at the beginning, like, why are we seeing the patient today? So there's different ways that we look at when we're scoring these elements of the HPI. And again, your new system in there has done a really nice job trying to assist with this also. But something that the system doesn't do the best job on, and I just want to talk about it a little for a minute, and I know as part of your focused educations that you're getting, they're really spending time showing you this, but there's 2 ways to score an HPI. The first way you can score an HPI is the status of chronic conditions being managed at the visit. So is the focus of your visit that day the management of chronic conditions for the patient? So when we look at that, we look at, for that visit, are you looking to manage 1, 2, or 3 or more chronic conditions? We look at that in there. So the management of the chronic conditions helps to lead to that medical necessity for the service. And the important part of this, it has to be the status of the chronic condition being managed. So if you're managing their COPD and you're managing their hypertension at this visit, it's part of the visit, and we're going to manage this visit, we're going to look and manage again their hyperlipidemia. Part of the scoring for that on your HPI element is going to be the status. So the COPD status might be they had an exacerbation in the last month as reported by the patient, or they had to increase the use of their inhalator, or their oxygen was increased, something to give the status of that chronic condition. Just listing that you're going to be managing their hyperlipidemia, their COPD, and their hypertension would not suffice for the purposes of the status of the chronic conditions for your HPI elements. So it does require us to put in a status of those. that it's remained stable over the past month. Patient reports it's been exacerbated, et cetera. So you need something in there. So, and just as a reminder, too, that if you're going to score your HPI by the status of your chronic conditions, that does not that does not cover us when we're doing our assessment and plan for what we're going to be doing for the patient for those same chronic conditions that we're managing this visit. So it's two separate areas that are scored as part of our service. So the status of the chronic conditions would be listed as part of our HPI elements. The other way we can score HPI is by the elements that are there. And this looks at the different applicable elements that are there, the location of the issue, where it is, the quality of the issue, that's a description of the type, the severity on a scale of 1 to 10, do we have pain, how long have they had the problem, is there any timing that triggers it, is it worse in the morning, the context, does it occur in relation to anything else when they're exercising, walking, sleeping, are there any modifying factors, anything that makes it worse or better, such as when they increase the oxygen, they feel better, and associated signs and symptoms, or any associated signs and symptoms. So these are actually what you've been traditionally used to seeing, I think, in your EMR, is that location, quality, severity, duration pieces. But I do want you to know, for the purposes of scoring your HPI, if you give the status of the chronic conditions you're managing today, as part of your HPI, these elements are, you can put them in there as giving additional detail, but they're not necessary for the scoring of the service for that history element. And if I'm not making myself clear on that, make sure you ask me some questions that we're going through. So if you got called in because the daughter or the patient called because they've been not feeling well for the last week, then you're going to put in there, you're seeing the patient today because they called because they've been having a cough and a fever for the last week. So we have a duration. Their temperature's been as high as 101, so we can have some issues there for the severity of what it is. The cough is associated as worse in the morning, and it gets better as they get up and start moving around. So we have timing for that. They've been taking over-the-counter Mucinex and Tylenol, so that's a modifying factor that we have there. And they also have a slight sore throat, so we have an associated sign and symptom. One thing about the EMR systems is, and that's why we've set up for you to be able to now put in the HPI section, free text, because that's one of the most important, giving good information about, you know, call to see patient, has been having a fever and cough for the last week, says it's worse in the morning than it was, but gets better during the day. They've been increasing their oxygen and taking Tylenol and Mucinex over the counter, and their throat has been sore. That HPI write-up just sets the whole tone for the entire visit, and that's we were really looking for a good free text, couple sentences why you're seeing the patient today. The one disadvantage to the EMR system for you, and as you get better and better and better at being comfortable with assigning the level of service, if you don't click certain items in the EMR system, it doesn't tabulate those for you in the end when it's able to tabulate how many different boxes you checked. However, we're real proponents of putting that HPI and actually spending the couple minutes to type that in there, because that really is why you're seeing the patient today. And I think probably of the entire record, the most important piece of that record. So this might be an area where the EMR is not going to pick up the actual items that are there, and you're going to have to use your slider to know that you covered what you needed to for the level of service, even if it didn't tabulate it for you as part of the electronic record that we have there. So tell the story what's going on. I will remind you, too, that the highest level services require you to have 3 or greater status of chronic conditions, or 4 or more HPI elements. So if we have where the issue is, how long they've had it, what are they doing for it, and they have associated signs and symptoms, that would be sufficient amount of documentation in that HPI to cover everything, without having to worry about the slider, et cetera. So a nice HPI, that's really something we really are pushing on the, advocating that you really try to do a nice HPI and document that HPI in there. So if anybody has any questions on that, let me know. If not, I'll move on. Okay, the next piece for the history area is the review of systems. And the review of systems, you've seen this, the review of systems is that area of systems where we're asking those head-to-toe review of systems that are going on. I will tell you that the review of systems section that's there can be done by either going over all the review of systems that are in there. On our new patients, we tend to go over all the review of systems. It also can be done, and it can be contained in the HPI. If you covered review of systems area in the HPI, then we count those also as a review of systems. You don't have to redocument the review of systems if you covered the fact they had a cough in the history of present illness. So it can be done individually and confirmed in the date of service. It can be counted as part of the HPI. It also can be documented if you noted every single review of systems, all 14 review of systems. You can also note that except as documented in the HPI, the remainder are negative. I do caution, though, after the first visit where we are probably getting 10 or more review of systems, it may not be necessary to do 14 review of systems again. I think it's really important to understand that for even your higher level services, asking the pertinent review of systems, 2 to 9 of those review of systems is usually sufficient for any level of service we're going to be billing. Your initial first visit, we want you to have and you're going to get this anyway because you're going to cover this generally on your first visit, but 10 or more review of systems is considered a complete review of systems. So again, that complete review of systems can be done by individually going over 10 or more of those. It can also be done by noting, having a really good HPI, and then noting except as noted, the remainder are negative, and that means all 14 review of systems was done, or just utilizing your HPI. If you're going to not see a new patient, you can utilize the HPI, which probably has 2 or more review of systems in it. So asking the patient if there are any changes since your last visit, and I caution practitioners by this, if you say, are there anything changed from the last visit, and the patient says no, that does not mean except as noted in the HPI, the remainder are negative. If you're going to ask that question, you need to go over every single review of systems in that, for that patient. So except as negative or all reviewed and remainder are negative means that all 14 were asked that visit, on that visit. So these are the review of systems. These are the 14 review of systems that are done. And again, the whole idea for the review of systems, just so you understand, is designed to bring out clinical symptoms which the patient may have overlooked or forgotten. That's really why we do the review of systems. So if you're doing a follow-up on that patient for specific issues, and you're going to go over, most practitioners have the same review of systems they go over every time, no complaints of X, Y, or Z, et cetera, that's perfectly fine for you to do on the visits that you're doing. If you're clicking things in the HPI, in the review of systems section, remember that you asked them. That's something that you asked on that visit. So the chief complaint, history of present illness versus review of system as complained. And I put these examples in there the last time when we had done them. But I think that as you're transitioning to the new EMR templates that we're using, this probably is not an issue anymore. So I might just spend just a minute. What happened in the old system was we really were mixing why the homebound, home limited documentation with the chief complaint HPI. This is how it used to be laid out, chief complaint HPI. So most of this, if we go back and review what a good HPI is, this really was a homebound home limited documentation that we sort of mixed together with the HPI. So in the new system, the new documentation system, the HPI now should be very clear. You're here to see the patient today for X, Y, and Z. This is what's going on for the patient today. And we won't be mixing up the homebound home status, home limited statements with our review of systems or the chief complaint history, present illness. The other thing in the old system was it used to say, and actually this says this in the new system too, we have not been able to change this, but we have in there the ROS in there sometimes says patient complained of. When we're complaining of it, sometimes it doesn't make sense what's in there for complained, but it is one of the defaults in the system that's there. So if you, the other recommendation I will say is if you have a family member who's giving you the information, and we've talked about this too, we have family member, make sure that that's documented in there, that there's a family member there providing some of the information. So I'm going to go past this one now because I think that we've probably addressed some of these issues in the new, any of you have gone through the new updates, and those that are in the process of the updates, you'll see the significant changes in the documentation in the end. And I think if you print out some of your notes in the new system, you'll see how good the notes are now, how much easier it is to follow what's actually happening with the patient. So again, this was an example of the review of systems section that was in there, and it, so in the old system, and I believe the new one, the patient complained of memory loss and poor historian. Obviously, the patient didn't complain of their memory loss. The patient has memory loss, but this is part of that default that they complained of. Some of that system is going to stay in there, but I just wanted to bring it out to you so that you could understand and see what it looks like, that they complained of fatigue and insomnia. And this was a patient who had significant memory loss and had severe dementia, where we said that they were complaining of. So anyway, that's a default that's in there. You will see some of that, and you'll see it doesn't make a whole lot of sense, but we've gotten past that to understand that that HPI is actually going to tell us why you're seeing the patient that day. So the last one is the past family social history, the PFSH we call it. Initial visits, again, we generally get a past family social history as part of that initial visit. On your follow-up visits, again, it's really only important to include in your visit note what was important for that visit that day. And again, I think that we generally have our patient's medications that are in there. That is sufficient in our note if we've got their current medications that are in there to give the history that we need for most of the levels of service that you're providing, because that would gives us our past history. Patient's medications would be sufficient to have in there. So after we do those initial visits again on our follow-up visits, it's really not necessary to bring into the notes or reference the family history again unless you need to do it to manage that patient that day due to their chief complaint or history of present illness. I understand that some of this stuff is in the system already, but populating into your note and to cause the note to have that in there isn't necessary on each note to do for the purposes of billing, coding, and actually for what you're providing for that patient that day. So documentation, chief complaint history, present illness can be listed separately again or as part of the HPI. The review of systems or past family can be obtained during earlier encounter and can be used again if completely reperformed, revalidated, medically necessary to treat the patient. Note the date and location if you reviewed it somewhere else. If you had an initial intake form and you reviewed that with the patient, note that in there. And you can update the information or confirm that where there have been no changes if they've all been reviewed. And again, part of our goal here is to make the flow of the note a better note so it actually gives what needed to be done that day. It documents what you did that day, all that cognitive service that you provided, and the note flows to show that. So just remember that it can be recorded by anybody. The patient's family can give you that information. If you see a patient, you're unable to get the history because they don't know it, just put in there that it was unobtainable. Let's say you're in assisted living facility with someone or at a home visit with someone and the family member's not there and they don't know some of the history and it's unobtainable. Just make sure you put that in there, it's unobtainable and why it's unobtainable. So this is just to show you from a coding standpoint. Again, you're not going to have coding sheets there, but I just want to sort of show you. Let me see if I can. I don't know if I can do a pointer here. Let me see. I'm almost afraid to do it, but I'm going to. So this would show you that when we're coding your services, we look at how many different, I don't know how to do it. Oh, let's see. Oh, well, oh, there we go. Well, we would go through your documentation, or if we were going through a review, we document how many different chronic conditions that you give the status of. Did you do 1, 2, 3, or did you give me the location of the issue, the timing of the issue, the modifying factors, the associated signs and symptoms. So for the HPI, we do if you did the status of 3 or more, or if you did 4 or more HPI items that are there. So that's how we end up coding your services. How many review assistants did you document on? And then did we look at how many past family social histories did you document on? And we go over and we just code how many of the different ones you documented on. So I will tell you, except for your initial visit, your highest level initial visits, one history area, again, if you utilized your medication list, would be sufficient for any level service you're going to do. 2 to 9 review assistance area is all you're going to need for your highest level that you would be billing in your services. And then 3 or more chronic conditions or 4 more HPIs is the most that you would need. So again, you don't need to do those family histories again. You never need to do them all 3 again. But if it's medically necessary to manage the patient, then you can do that. Then you would do it. Okay, that's our history. And I focus on that again because I think that the history and that initial piece is really the crux of what you do, obtaining why you're seeing the patient, and then that assessment and plan at the end. The next thing we have, step 2, is the examination. We have a problem-focused, expanded problem-focused, a detailed, and a comprehensive exam. There's 4 levels of examination. We look at what we're using now, and I think you've all been familiarized with this now, is what we call the general multi-system exam. The general multi-system exam we're using on the 1997 exam. And this actually counts how many different exam areas you documented on. Whether we did 1 to 5 different exam bullets, which is a problem-focused. An expanded problem-focused is at least 6 bullets. A detailed exam is at least 12 bullets from 2 or more of our systems. And a comprehensive exam is at least 2 bullets from each of 9 systems. So these are this is what comes up now in your EMR, which is just really nice. They spend a lot of time setting this up to make sure in the examination you'll see a constitution. And in the constitutional, there's 2 bullet areas, the measure of 3 or more of the 7 vitals, and then another constitution bullet would be general appearance of the patient. So if you measured 3 or more of the vitals and you did a general appearance of the patient, then you would check off both of these, and you would get 2 bullets. So that would be considered the 2 bullets or elements that we do. These are the different bullets for the eyes, inspections of the lids, exam of the pupils and irises. And again, you're going to check those off if you did them. One of the interesting things about the 1997 examination is that it does require you to it does require you to document, to perform exactly what's in that bullet. So if you're going to do an examination of the pupils and irises, you have to do both the pupils and irises. If you did just the pupils and not the irises, let's say, then you don't get credit for that bullet. So again, I think that they've set, Amanda, Sandy, they've set that those exams up so that that meets exactly what the requirements are. So if you check that bullet, it means that you provided that bullet. Here's the ones for ears, nose, mouth, and throat. These are the neck examinations, examination of the thyroid, examination of the neck, and that's two different ones. So if you did the neck for masses and overall, and you felt in for the examination in the middle of the thyroid and there's no enlargement, etc., then you get credit for 2 exams on the neck. Cardiovascular, chest and breast, GI. This is the GU, which we have the male and female examinations for. Lymphatic, musculoskeletal, skin, neuro, psych. And then here's how we look at these exams again. If you did 1 to 5 bullets on any areas, it's a problem-focused exam, which is our lowest level examination. If you did 6 to 11 bullets in any of the areas, then that's an expanded problem-focused examination. If you're going to do a detailed examination, you do one of the following. Did you do at least 2 bullets in each of 6 body areas, or are there a total of 12 bullets circled in the areas? So if you had 12 bullets that were in here in the areas, with at least 2 areas, you would have that. But the comprehensive is at least 2 bullets in each of 9 body areas. So if you're going to do a comprehensive exam, the highest level, there has to be at least 2 bullets in at least 9 of the areas. Any questions about the exam? All right, and the last piece is our medical decision making. This really is used to determine, together with the HPI, why are you seeing the patient today and what are we doing for the patient today. They're really the 2 hallmarks of our E&M services. And so it looks at whether you did a straightforward medical decision making, a low complexity, a moderate complexity, and a high complexity. So when we look at the medical decision making, and this is one area that can never be scored, it really cannot be scored in the electronic system, because this really is a culmination of all your cognitive services that you provided that day. There's not really a place where we're checking off some of this stuff. This is what your assessment and plan is putting together at the end. It looks at the number of diagnosis or management options that you were presented with, the amount and complexity of the medical records, diagnostic tests, or further information that must be analyzed and reviewed, and the risk for the patients for complications, morbidity, or mortality given the patient's diagnosis, diagnostics, or management options. And that risk is determined between now and the next time you're going to see the patient. So somebody who's a higher risk for complications, you may see more frequently because it's a risk between now and the next time you're going to see the patient. And someone who you feel is not as high of a risk, then you might not have a visit as close together as you might for somebody who you have an expectation that they have a higher risk. So let's look at the first one. The first one is the number of diagnosis or management option. This indicates and asks you to clearly indicate the diagnosis, whether they're controlled, improved, or worsening, indicate any differential diagnosis, indicate the treatment plan, and indicate any referrals or requests that were made for consultation. So remember in that HPI, we're going to give the status of 3 chronic conditions that are there. Down in our medical decision making and our assessment and plan, if you said somebody was stable up in the HPI for the purposes of the HPI status of 3 or more chronic conditions, in our assessment and plan, we don't need to put, again, that they're stable in there. We're going to put that what the patient has COPD, and they're going to continue with their current inhalator and oxygen and O2 at 2 liters. you don't have to actually reiterate what was up there, up in the HPI for that status of there, but in the assessment and plan, we're going to put what we're doing. And if you've listed somewhere that they're already on their 2 liters of oxygen that's listed, you can put that they're going to continue with their current oxygen level. So we don't want you to double do work that's unnecessary to double document if it's documented somewhere. But in that assessment and plan, I will tell you it's very important to do 1, 2, 3, 4, what the diagnosis is you're managing and what you're doing for the management. So you're going to manage your COPD, we're going to continue with their O2 and their inhalator. You're managing this on this visit, we're going to continue with this. You're managing this visit, and we're going to increase something. The patient presented with this today, we're going to make a recommendation that they see an ENT. We're going to consult ENT. So this is, again, where we're looking at what those things that we're managing today and what we're doing about those things today. And it's not just a list of chronic conditions. So if you're listing just all diagnoses, we consider the list of diagnosis medical history. The assessment and plan is what you dealt with that day, managed that day, and what you were doing about it that visit. So a list of diagnosis doesn't count. That's a medical history. And that assessment and plan, it's the diagnosis and management options you did that day. So you may have someone who has hypertension, but we didn't manage it this visit. We managed it last visit, and we're managing their COPD this visit. So listing the diagnosis is medical history. Addressing the diagnosis this visit becomes part of the assessment and plan. Next is the amount of data that's reviewed and ordered. So if you ordered lab work from the last visit and you reviewed that, this is where you could put that the labs were reviewed and shows their hemoglobin remains such and so. You also can just reference the lab that you reviewed the lab, as long as we can see that you did review the lab. My recommendation generally is when you review labs or radiology, they had something done ahead of time. They had a chest x-ray that was done. To note that in there, chest x-ray reviewed and infusion and the pneumonia is clearing in the left lung, I'll just put. So, but this is where you're going to put anything that you reviewed, any tests that you reviewed or ordered that were there. If you are ordering labs, you get credit for that too. If you ordered labs, you get credit for it, or if you reviewed labs, you get credit for it. So you can, if you listed the labs you ordered that visit, if I can see that you ordered before the next visit, we're going to do a CBC, et cetera, that's sufficient too. If we can see that it was ordered that visit, you would get credit for it. So this is how this tool works. Again, on that left side there, medical decision making, the number of diagnosis or management options. Let's see if I can do this again. So this goes, how many different problems did you address today? Did you address an established problem to you that was stable or improved? You get points for that. This works out as points. So again, we actually put a number in here. Their COPT was worse today, so you get 1 there. Their hyperlipidemia and their hypertension were stable today. You'll get 2 there. So you get 2 diagnosis that had a point each for 2 points. You had 1 diagnosis, COPD, that was worse today. You're going to get 2 points for that because you get 2 times 1, and we total it down here. So that's how that service works. That's why it's very important to know in your assessment and plan, even if you didn't put stable, improved, et cetera, we have that up in the HPI, we're putting what we're doing for that problem. The COPD, we're going to increase the oxygen. That's a worst issue. So that's how we look at those. That goes in here. Then we look at the amount and complexity of the data. Did you review or order labs? You get a point for that. Whether you reviewed 10 labs and ordered 7 labs, you get 1 point. Did you review or order any radiologies? Did you review or order anything in the medicine section, consultations? Did you discuss test results with someone? Did you call a provider? Did you review or summarize old records that were sent in? Did you request old records? If you reviewed or requested records, you get credit for that. One thing that's interesting is if you obtained history from someone other than the patient, we put that in there. However, I will tell you, if the way that works for especially for our dementia, Alzheimer's patients, as well as for our very young pediatric patients, it's both sides of the spectrum there. We only give you that credit for obtaining information from someone other than the patient when the patient was able to contribute some information and the other person contributed additional information. If all the information is obtained from one person, then you don't get credit for that in there, just so you know. So the last one is the risk of the patient. This looks at the risk for the underlying diseases that you address, treatments that are being provided, ordered, planned, or scheduled procedures that are being done, any surgical or invasive procedures that you are ordering to be performed, or a referral for a stat issue or a transfer to the ER. So this is our risk table. So it's interesting, the way the risk table works is, and this is one thing that sets apart some of the services that we're providing that sometimes impact the medical necessity for the level. The risk table was set up for what the risk for the presenting problems is, diagnostic procedures that are going to be ordered or planned, and your management options. And the way the risk works, it's, I don't know if you can see my pointer when I'm using my pointer there. So we look at the presenting problem. We have 2 or more self-limiting or minor problems. If you have any patient that you're addressing that has 2 or more stable chronic illnesses, it's a moderate risk. If you have a patient where you're providing any prescription drug management, it's a moderate risk. It goes to the highest risk in any one of the 3 tables that are there, any one of the 3 tables. So whether it's the presenting problem, the diagnostic procedures, or the management. So if we saw a patient today and we had an acute, uncomplicated problem that we saw them for, it was a visit we called in because they had a cyst on their arm, and we considered it an acute, uncomplicated problem for low risk. But we ordered amoxicillin for the patient for prescription drug. That brings it up to a moderate risk. It's the highest risk in any one of the tables. So for our patient population, it would be unusual to have anything, most times, below a moderate risk patient. We could have someone who's a low risk that we came in, they had a problem, what we saw them for, and we told them to use over-the-counter medications or et cetera, that would be a low risk. But once we order a prescription drug for a patient, or we have 2 or more chronic issues that are being addressed, those patients fall into the moderate risk category. So the way this system works is, the way that we do it, only 2 of the 3, either the number of diagnosis or management options, the amount and complexity of the data, or the risk of the patient, 2 of the 3 get counted. So if we have a patient who has 3 chronic illnesses that we're managing, and one of them is worse, and we had 4 points for that, we would have 4 points. And we had labs and x-ray that we did, and we're ordering prescription drug management, that patient falls into a moderate risk for the 3rd component of the medical decision making. They fall into a moderate complexity patient. So any questions on the medical decision making for the medical decision making components? And again, this medical decision making really is that assessment and plan. what it is we're doing for the patient today, what it is we reviewed or ordered. If we reviewed labs and that's in there, we get credit for that in there. This is taking what we're doing for the patient that day. So let me just talk a minute about the diagnosis. The diagnosis that we assign to those services that day are why we're seeing the patient that day. So we are going to assign the diagnosis of that COPD. We're going to assign that diagnosis of the hyperlipidemia and the HTN because that's what we were addressing that day. And it's all the services that we address that day, not all the diagnosis the patient has. So on that claim would go the diagnosis we address that day. And as specific as possible, I'm sure you're all aware, and we do have, I think, our smart templates where we can go in to pull out those diagnoses, and I think we'll work more on the diagnosis as we get more comfortable with the E&M portion of it for the specificity of those diagnoses. So we look to do that, and again, we're going to assign diagnosis based on why we saw the patients that day. So let me talk about the medical necessity, because this has been a little stumbling block for our subspecialties. And I do a lot of work with a lot of organizations who do home visits and assisted living visits. And the last piece we look at is the medical necessity for the level. And what they say is ignoring how the medical necessity affects the E&M level can put us at risk. And this is in accordance with the CMS, with the Medicare manual. And it says that the medical necessity of a service is the overarching criteria for the payment in addition to the individual requirements of the CPT code. It would not be medically necessary or appropriate to bill a higher level service of an E&M service when a lower level service is warranted. The volume of documentation should not be the primary influence upon which the specific level of service is billed. Documentation should support the level of service reported. That is, a provider should not perform or order work or bill a higher level if it's not necessary based on the nature of the presenting problems. So one thing that doesn't exist for us is a little checkbox that says what's the medical necessity of the level. We only have the checkboxes for the history of the exam and medical decision making. So one thing that we look at when we're doing the medical necessity of that level, so the health services that practitioner exercising prudent clinical judgment would provide to the patient for the purpose of evaluating, diagnosing, or treating an illness, injury, disease, or its symptoms, and that are in accordance with generally accepted standards of practice, clinically appropriate in terms of time, of type, frequency, extent, site, and duration, and considered effective for the patient's illness, injury, or disease, not primarily for the convenience of the patient, physician, or other practitioners, and not more costly than an alternative service or sequence of service that could be produced. So for us, for medical necessity, it looks at when we're seeing the patient, assigning a level of service that's medically necessary, not based exclusively on how many bullets did we document, but what was medically necessary for that patient in accordance to why we were seeing the patient. And that the frequency of the visits that we're seeing the patient are clinically appropriate in terms of what's happening with the patient. Meaning that we wouldn't necessarily expect that every patient needs to be seen every month. Some patients maybe need to be seen every week based on what's happening with them, and maybe other patients need to be seen every 2 months or every 3 months by the nature of their presenting problems. We look at, and one of the things that we deal with when we're dealing with patients that are being seen in their home or in the assisted living facility, instead of being seen in an office setting, we equate that to that patient generally is someone, maybe in an office setting, if I go and I audit patients with chronic conditions in an office, most likely the majority of them are being seen quarterly, every 6 months, or annually, having shadowed many, many internal medicine nurse practitioners as well as physicians. The frequency generally is on the 3, 6, 12-month frequency when things are being managed and under control. If we have a patient who's coming into the office setting and it's not, we might see them back weekly, we might see them back in 30 days, or we might see them back in 2 weeks. So we use the same prudence when we're seeing them in the home at the frequency that we need to see the patients to manage their diseases, to manage their chronic conditions, and to keep them at the lowest risk. So that's what we look at, again, when we're looking at medical necessity. And when we're being audited, all of my home services that are being audited, the CMS comes in and looks at the frequency of those visits in accordance with what needs to be, what the frequency is to manage the patient, in addition to what the level of service is that's being billed for the patients. So the purposes of generally accepted standards of medical practice means standards that are based on credible scientific evidence published in peer reviews, medical literature, generally recognized by a relevant medical community, physician specialty societies, the views of physicians practicing in a relevant clinical area, and other relevant factors. And please remember, for the purposes CMS publishes the word physician, physician means other practitioners, including nurse practitioners. So again, this gets back to that medical necessity of what is generally medically accepted standards, including the frequency of the visits as well as the level of service that's being billed. So document and perform what is needed on the date of service based on the reason for the visit, and code based on that reason for this visit and why you saw the patient that day. So that's our medical necessity. So here's our puzzle. I'm just going to go over these sort of quickly. These are your new home visit and assisted living visits. These are considered new visit level 1s. In a home visit, and just so you know, domiciliary and the home visits, the assisted living, the write-up for them is exactly the same, except for the CPT code and the introduction of that code. So home visit, this is the code for assisted living. The entire rest of the description is exactly the same. So for level 1, new patient requires problem-focused history, problem-focused exam, straightforward medical decision-making, counseling, coordinated care with other physicians or qualified healthcare professionals or agencies are provided consistent with the nature of the presenting problems and the patient's overall family needs. Usually the presenting problems are of low severity. Typically 20 minutes are spent face-to-face with the patient and family. So the write-up is exactly the same for whether we're a home visit or an assisted living for a level 1. And I'll talk about that time later, so don't stop this annotation. All right. Level 2, same exact thing. Expanded problem-focused history, expanded problem-focused exam, and medical decision-making of low complexity for level 2 new patient visits. Usually the presenting problems are of moderate severity. So level 2 new patient, usually the presenting problems are of moderate severity. A level 3 new patient visit requires detailed history, detailed exam, moderate medical decision-making, and usually the presenting problems are of moderate to high severity. So a level 3 new patient visit, usually the presenting problems are moderate to high severity. A level 4 new patient visit, usually the presenting problems are of high severity. So 99344, 99327, usually the presenting problems are of high severity, typically 60 minutes, and that's going to do with our counseling coordinating care. And then the highest level, 99245, which is a new patient level 5, and a new assisted living, which is a 99328 code actually. Usually the patient is unstable or has developed a significant new problem requiring immediate physician attention. That's the write-ups for the level 5 new patient visits. Established patient, home visit, or assisted living level 1. Just so you know, we call them level 1s. I know internally you call them level 1s, 2, 3, 4s. Just so you know, the CPT code is a 99347 for the home visit, and for the assisted living it's a 99334, which is your level 1s. Level 1, usually the presenting problems are self-limiting or minor. So that might be someone that we were called in to see. We went in, they had what they thought was a lesion on their hand, let's just say, I'm picking something, and we go in and it's a mosquito bite. It worried them, they were worried about it was red, but it was a mosquito bite, and we're just going to have them watch it. That might be somebody who's level 1. Very straightforward, very self-limiting. They're considering a self-limiting problem something where that after the course of treatment, the diagnosis goes away. A level 2 follow-up visit, which again, these are the majority of your services are your follow-up visits. A home visit is a 99348. Assisted living is 99335. These are your level 2s. It says that usually the presenting problems are low to moderate severity. Usually the presenting problems low to moderate. Typically 25 minutes are spent, and that's when we're doing counseling coordinating care. A level 3 visit says that usually the presenting problems are moderate to high severity. So an established level 3, usually the presenting problems moderate to high. A home visit is a 99349, and assisted living is a 99336. And then your level 4 visit says that usually the presenting problems are of moderate to high severity. The patient may be unstable or may have developed a significant new problem requiring immediate physician attention. So again, it's the same write-up. So your level 4 visit for a home, the highest level is a 99350, and a level 4 visit for assisted living is a 99337. So when you leave the patient's home, whether it's their private home or whether it's assisted living, there's generally 4 levels of service you can bill. For the majority, a level 1 service, presenting problems usually minor. Level 2, usually the presenting problems are low to moderate. A level 3, presenting problems are moderate to high. And level 4 service generally require immediate intervention. We could have someone with a severe exacerbation of their COPD, and we're going to increase their oxygen. We're going to do this. We're going to manage them. Generally, anyone we have in there where we tell the patients or the patient's family, if there's no improvement, we want you to go to the emergency room. Typically, they're the types of patients that are the highest level, typically. That doesn't mean that they all have to be going out to the emergency room. It's not what it means, but typically those 5-0 services or 3-7s, which are our level 4 services, have the highest level of intervention needed, and we might be going back to see them tomorrow or 2 days, et cetera, that follow-up visit it's going to be close by because of the presenting issues. So we did set up coding cards, and I think everyone has gotten them, where we set up for you just hints for you for what the levels of services are. These are your new patient homes and new patient assisted living. I know I'm not using this too well here, and I apologize. So new patient home, new patient assisted living, there's the codes that are there, and this tells you how many HPI, how many review assistant, how many past family social, what the exam level would be, and then the typical time associated with that, and that time is only for counseling coordinating care, which we're going to do additional in-servicing on. These are the established levels, patient home, and then the patient and assisted living, and what's required from that. And then these are the coding cards that we set up for everyone. And again, for these coding cards, the one side has, and I'm going to concentrate on your established, the one side has your home visits that are there, your new patient home, and this is the majority of what you provide. These are your established patients for home visits, and these are your established assisted living patients, the levels. And I generally say when a practitioner comes out of a home of a patient, there's 4 levels of service, 1, 2, 3, 4, and for the most part, you generally know if you provided a level 1, 2, 3, or 4 service. You generally are going to know that. And that there's a scale in there. We provide probably very few level 1 services, and I'll call them level 1 for that purpose. We provide very few level 1 services that are going on because those patients typically, we're not addressing one small thing. The majority of our services fall into this area, which is our level 2s and 3s, generally our 2s and 3s. That's typically where they're going to fall into. Our level 4 visits are those that are unstable. We got called in because there was stuff going on with that patient, and we're doing intervention. That's generally our highest level. Typically, and then the difference really between the the level 2 and the level 3 visit for both of them, remember the level 2 and 3 visits say that the presenting problems still, for those visits, those level 3, the presenting problems are moderate to high severity for a level 3, and the level 2 visits, the presenting problems are low to moderate severity. So are they low to moderate severity or are they moderate to high severity, looking at from a medical necessity standpoint? And then the back of your cards, we put all the exam areas in there, and then we put just the key to the medical decision making so that you would have that also. I know the type is small on it, but we really felt that at least for this first round, it would be nice to have all that information for everyone to have. So that's what those cards look like. And these are the individual coding cards that we had made, which is just the one side has the home visits on it, and the other one has the assisted living visits on it. So I'm not going to spend a lot of time with this, but I just wanted you to know, for those of you that have seen it, and we are going to do separate education on this, when you're looking at the time that's associated with those codes, because when you read the write-up on them, there is time associated, I just want you to know that that time is associated when you're providing counseling and coordinating care. We generally recommend that practitioners do not document the total time of the encounter that you're there. It's not necessary to, if you're using the key components to history exam and medical decision making. The only time we would document the time is when we didn't have to do very much history exam and medical decision making, and that visit was really dominated by counseling and coordinating care. And that's when the time component comes into it. So counseling, coordinating care, as defined, Medicare Compliance Bulletin puts it in as and the CPT manual makes a distinction between psychotherapy and counseling. Counseling is defined as a discussion with the patient and or family concerning one or more of the following: diagnostic results, impressions, recommendations, prognosis, risks and benefits, instructions for management or follow-up, importance of compliance, what shows the management, risk reduction factors, patient and family education. So all those are important pieces that go into when we're counseling, coordinating. So this might be the patient that's been non-compliant with what we've been doing. Things are getting worse instead of better, and we're spending a great deal of time with the patient and family over risk reduction and compliance with what they're doing. So again, for those home services that we look at, when we're talking about that piece that's there, these are some write-ups that are about those home visits that are put up by CGS, who is our Medicare write-up. So for those home, so you know, let me go back to this one just for a second. I'm sorry, I don't mean to jump around here, but I forgot that was the next one. So that counseling, coordinating care, if we are spending 60 minutes or more with the patient and family, and we're doing it and not having the history exam medical decision making, that's when this piece of counseling coordinating care will come in. And I think we do have some opportunities for that. It's just for the purposes, if you are considering that, we are going to do some additional education related to counseling coordinating care. Again, don't document your time. It's not necessary to document your time for a visit unless you're going to do it for counseling coordinating care, because you don't have to spend 60 minutes with a patient to bill certain levels of service, only if you're going to do counseling coordinating care. So I put in here a couple things. CGS, just so you know, is the Medicare carrier for some of our areas where we do our practices. They did some write-ups in about Part B for home visits. This was specific for home visits. This is CPT codes 99341 to 99350. And CGS has done some reviews of home visit codes, and some of their conclusions on their visits, on their audits that they did, not related specifically to you in any fashion. This is general for CGS that they did. That the findings included failure to support the medical need for the home visit in lieu of an office visit, failure to meet the key component levels required to build a code, and the medical necessity not supported. So that's 3 significant, distinct items. Failure to support the medical need for the home visit in lieu of the office visit. That is why we have our statements for homebound, home limited. And in the new system, which is really nice, it's not mixing it with our chief complaint history of present illness. It is a tab that we're having where we have the homebound, home limited statement that's there and the documentation to support why they're homebound and home limited. We do have patients, and I saw lots of the notes, I've looked at lots of your services. We have patients who do meet homebound, home limited. Maybe they've come, they're on your service because they had recent surgery, or they came on service because of a significant decline, and they're homebound, home limited services. And then we have some that those same patients become non-homebound, home limited, and then they can return to going to the office setting. So when we have that, when they are able to return to that that office setting, because they no longer are homebound, home limited, we need to stop their services and they need to go back to see a physician in the community, because our services can't be provided strictly for the convenience of the patient. It can be for the convenience of the patient if they're homebound, home limited, or they require their caretaker to have to take them out. They still can qualify. If, however, they're out driving, doing all their own stuff out there, we can't provide that service in the home to them for their convenience. So that's a really important distinction, so that if there's a point at which the patient does not qualify for home services, then that particular patient, we need to change them back to the community setting. And that's very difficult in our setting oftentimes, because many times we are their primary care provider. You are their primary care provider, and in the community, that primary care provider they had before isn't any longer. You consider them your patient, but there are specific requirements in order to provide services in the home or assisted living, so either location. So that's the first one. Meet the key components. We've talked about those. You have to at least meet the key components. So we can't bill a higher level service if we didn't meet the documentation for the history exam medical decision making. So that's those key components. And then the third one is that medical necessity. So they say even though you do meet the key components, the actual write-up said that you have to meet or exceed, you did more than you needed to do because the medical necessity of the service really was not that high. So that is that one box like I talked about that there is no box for. And we have reductions in our services even when we can check box off that we met the key components, because the carriers, the Medicare carriers, CGS and others, feel that the level really wasn't medically necessary, that we could have billed a lower level of service even though our documentation supported a higher level. So that's why I say when our practitioners leave the home, whether it's assisted living or the homes in the home, 4 levels of that service can be 1, 2, 3, and 4. You generally know when you leave what level of service that was based on the necessity of that service, in addition to that you documented the service adequately. So due to the continued prepaid probe findings, GCS would like to provide guidance on documentation requirements, so specifically how it relates in lieu of and medical necessity. So requirements for physician presence. Remember, for these purposes, physician means practitioner. If you visit a patient in his or her home on a regular basis, be sure that each note shows how the patient's condition has changed. Avoid cloned or copied documentation that does not explain how the patient's condition has improved or deteriorated. And that's part of the reference manual for them. So that's why, again, those copy forward, that's why that note, that HPI, that's really the crux of what we're doing, and that assessment and plan. That is telling us what's happening with that patient on that visit and why that service was medically necessary. This is, again, guidance from CMS that they have on home and the assisted living code. So this is specifically from CMS. It says, physician visits to patients residing in various places of service. If we're doing services for rest home, et cetera, are used to report evaluation management services related to residents residing in a facility which provides room board. The CPT codes are used to report E&M services in facilities assigned to those levels of service. And again, it goes back to what CGS says here, that these all fall into that same, why we're providing the services there. The CPT codes for those home services, patients residing in their home or their private home, not residing in a congregate living situation or assisted living situation. They may not be used for billing services provided in settings other than the home services. And then we have the separate assisted living services. Requirements for the presence, they're paid when they are billed to report the E&M provided in a private home. And homebound status. Under the home health benefit, the patient must be confined to the home for services to be covered for homebound. The home services provided by a physician using these codes, the beneficiary does not need to be confined to the home. The medical record must document the medical necessity of the home visit in lieu of the office or outpatient visit. So that's why we say homebound or home limited. So they do not have to be homebound as they have to be home health services, but they do need to be medically necessary in lieu of the office or the outpatient. So that's why we do home limited. So in lieu of the office visit, we're seeing them in their home because of that home limited status. So that's what we're trying to show, that the patient can go out of the home, but they're home limited because they become significantly short of breath after 20 steps. Something along those lines. So that's that homebound, home limited status and why we have to have that, because the services in the home and the services in the assisted living pay differently than they do in the office. So if that patient can be seen in the office at a lower cost to Medicare, they want them to be seen in the office at the lower cost. Homebound, home limited, again, needed to support the medical necessity for the home or assisted living in lieu of the office visit. I put this in here only because I'll be 65 and not too many more years, but I think we've eliminated a lot of this stuff in the new system, which is great, because the patient over the age of 65, of course we would say, does not in and of itself mean that you're homebound or home limited. Must document each visit, why this visit was medically necessary for the home visit, the ability of patient causing it. And again, we don't have to populate. In the new system, there is that tab up there. We do need to make sure that it's opened and looked at, make sure that nothing's changed, needs to be added or deleted, but that will suffice. It does not have to be populated in our actual progress note. So I did put this in here just to let you all know that the services that are provided in that home and in that assisted living location are sorely needed nationally. I do believe this, and I've done work with these types of services since actually my look back on my first client that I had who did home visits, and it was a nurse practitioner really run practice with one physician overseeing, was back in the early 2000s. They were providing these services. But this was in the health news in 2016, too few doctors making house calls to homebound elderly. And it just put that there was a crisis in these services and a crisis for these home calls, because back in the early days, physicians and practitioners, physicians went out to the house to provide the services. Then they came to then everything turned to the office. And the problem is that the access to health care for many of these patients, they would not go and cannot go to the office, and therefore without your so necessary services, many of these patients would not be getting treatments and services and adequate services. So the services that you provide, this paper really shows how us that access to home-based health care is extremely limited, highly concentrated, and just not available to all who need it. So I'm not going to go through this. I just thought it was a really good article. I sort of cut and pasted in here since you all have this electronically, but it does show that it's so underserved population that although this is showing that more frail Americans are at home than in nursing homes, that 7 times more primary care physicians visited nursing homes than made house calls, even though there's more in the home. So this is a service that we need. It is, and I think part of the education we do when we go through reviews, and I go through and support services for many organizations that provide these services, is showing them how we have prevented these patients from going back into the hospital. We've prevented readmissions to the hospital. The services that you provide are so medically necessary and provide such care to our patients, and it's really underserved population. Unfortunately, it's a highly audited area because we do provide frequent visits. So when we come up on the radar, we come up because the frequency of our visits in the home, the frequency of our visits seeing assisted living residents, and that's why it's so important in your documentation that we're going to follow up on those patients, that when we do follow up on the patients, not everyone, there's no standard that everyone gets seen every month. That's not medically necessary. However, it might be for 95% of our population, and that's why the visit has to show why it was necessary to see the patient again in a month or in 2 weeks. Or can some of our patients go 6 weeks or go 60 days to be seen, or can they go 3 months to be seen? So you need to individualize each patient on the frequency of their visits and then for the level of service that we bill for those patients. So in-house audit findings, connecting the chief, these are audit findings that I've had through many different organizations, connecting the chief complaint, the review system, the exam, the medical decision-making, and the plan of care, and the nature of the presenting problem, so that the story can be told, and that when we read that note, we actually know what's going on that day, that visit for that patient. The review system and physical exam include elements to show what was done and why it was done based on the chief complaint and history of present illness. So when we're doing the review systems and we're doing exam, why are we doing those portions? Takeaways from internal audits. Document the severity of each condition addressed each visit and what you were concerned about today. Document the correlation between the acute condition being addressed and how it relates to chronic conditions that affect the severity for the patient, if applicable. The fact that the patient has a significant exacerbation of this is also affecting this because their blood pressure is going up, because their medications changed, etc. Connection between homebound, home limited, chief complaint, and HPI, which we are going to, they're 2 separate and distinct portions of our medical record now. So you don't have to in that HPI support that. It's going to be in that other section. The HPI on these visits is going to be why you're seeing the patient today. If mentioning acute issues in the chief complaints such as falls, injuries, self-harm, behaviors, etc., please make sure you address it in the plan. I have had some where we reviewed the patient had a fall, but there was no write-up in the assessment and plan. If in the history of present illness you put patient had recent fall, and make sure you document somewhere that there were no injuries and no follow-up is needed, not just listed in the chief complaint. Risk of falls, in-house audits, risk of falls and injuries, left elbow and hip with severe pain and associated pain and medical noncompliance of steroids for pain associated with it. Document how you're going to address the injuries due to the fall. Severe limited mobility, which makes the anxiety worse. Addressing the plan of care. If the anxiety is getting worse because of this limited mobility, address it if you need to address it. You might not need to. You might not make any changes to the patient at all, but you're going to continue to encourage the patient such and so. Again, if you're addressing it in the history of present illness, the reason for this visit, make sure you address it in your plan. And again, the plan doesn't have to be the assessment plan. I can see most things in any portion of the note. The only thing that needs to be separated is if you're using the HPI status of chronic conditions, that needs to be a distinct section of the status of chronic conditions. Intellectual disability is profound, address in the plan of care if applicable. If it's profound, it is, and maybe we're not going to need to do any changes. UTI in elderly with behavioral disturbance, distinguish between behavioral diagnosis from a secondary cause of traditionally defined medical diagnosis when there's no relationship documented, such as a differential diagnosis. The UTI in the elderly with behavioral disturbance, and again, some of this is, I think, going to go away with the new documentation system. And last one I'm going to do is the aggressive and combative harm to self and others, severe Parkinson's. Document if this is an acute issue that you're going to address. And if it is not history of present illness, we would expect to see it addressed in some fashion, that we're going to continue to educate continue to work with the family member to redirect the patient in some fashion. So follow from some of the E&M code selections, full review of all selected codes initially. Again, every single service that you're providing where you're identifying that level of E&M service, 100% of them are being audited. They're being coded, 100% of them. We're trying to do follow-ups for the practitioners for the week, for the feedback. We had set up and do have set up a dedicated email if you have questions when you're done here, and it can go into this a dedicated email system. And the reason we did that was so we could share your questions from the in-services with others. So if you have a question, maybe someone else does, so we can collect all the questions and address them to the group if you've got a particular question when you're doing something, especially the new practitioners who have never assigned an E&M level before. Some of our practitioners had assigned them for years and years, and then we didn't assign them for a while, and are very familiar with the documentation. Other practitioners, if you're new and have never done it, this can be a pretty daunting when you're trying to care for your patient to do these pieces, but I can promise you that over a short period of time, you'll get very comfortable with it, and you'll know what needs to be done. You won't need to have it assigned from your EMR documentation. You won't have to use the slide, those components. You'll know what that level was when you were done and be able to assign that level. More in the future, we're going to do documentation in the future on the hospital, the post-hospital and post-ED visits, how we might address those, the annual wellness visits, chronic care management visits, and any other recommendations you might have. So if you have recommendations for future in-services, future educations, please let your leadership know, because we want to be able to provide for you what it is that you're looking for. And again, looking at time for counseling, coordinating care, et cetera, we're going to be doing more education based on that also, so you understand what that is. So I'll open it up if anybody wants to unmute, if anybody has a question before we stop the recording. Does anyone have any questions or comments? Can someone just put in, just say no, so I know that the recording worked? Thank you, whoever that was. So I just wanted to be sure everybody could hear me throughout the presentation. All right, yes, thank you, everyone. Good, good. So no questions. I'm going to stop the recording. And I really want to thank everyone for joining us. It was really, I'm hopeful that it was educational, and for some new information, for some just a reminder of old education. And please feel free to address any questions, either directly back to Amanda Group. You can, and Sandy, you can email them back, or send it through to that one email, and everybody will be provided, if you haven't already, a copy of the presentation.
Thank you.
Thank you.